Program at Journal Club. And on behalf of myself and Professor Yi, we're the co-directors of the UT Spine Program. Welcome, and thanks to Nadia Jobber for organizing this. And we have kind of three interesting presentations. This is kind of a citywide collaborative effort. So Amit Cherry from Toronto Western, Raj Kumar from Sunnybrook, and Raj Sakrekar from SickKids Hospital will be kind of presenting different different themes. I think we can look forward to that, and want to also welcome everyone aboard, and thanks to Department of Surgery, Divisions of Orthopedic Surgery and Neurosurgery, and to our various commercial supporters for all of their support. And hand over to Albert, and then perhaps we can get going.
That's terrific. And so thanks so much, Michael. And it's great to see everyone this evening. And this is obviously a continuation of our University of Toronto Department of Spine Program academic calendar events. And that includes sort of various Journal Club sessions throughout the year. Many thanks to Nadia Jabber, our program coordinator and manager, for helping to keep us on schedule and organized with regards to the venue and meeting this evening. Special thanks to Amit, Rajesh, and Raj for helping to select some of the articles and bringing forward a few case presentations, along with some interesting articles, I think, that will cover aspects relating to fellowship and surgical education, as well as some of the nuances relating to patient selection for surgery, indications in terms of fusion levels in deformity surgery, and other things, I think, that are at sort of a higher level of thoughts as it relates to management of patients with sort of more complex spinal disorders. Welcome to the faculty and to the attendees for this evening. And I guess I'll turn the virtual podium over to Ahmed and team, and look forward to the dialogue this evening.
Okay, look forward.
Thank you, and Dr. Phelan.
Thank you. Please.
As indicated, I'm Ahmed Cherry, one of the clinical fellows from Toronto Western Hospital. Thanks to Nadia, Dr. Phelan, and Dr. Yi for having us this virtual journal club. So what I'll be presenting is actually an educational paper, the importance of determining training perspective on procedural competencies during spine surgery clinical fellowship. And this is a paper that does have collaboration with Dr. Yi, as well as Dr. Phelings and our colleague, Dr. Jeremy LaRouche at Sunnybrook, and others at Vancouver. And the reason why this is important is, if for those that are unaware, Canada is currently undergoing a selection, or I guess a process, of which we are making the spine fellowship accredited as a diploma. So a lot of this educational points are coming out throughout this. So with regards to some of the background, surgical education continues to evolve and increase focus on competency-based training. So for those who don't know, a lot of our residency programs have now completely became competency by design, which allows graduates to at least move on earlier than the scheduled 4 or 5 years of residency. The increased number of complexity of spinal procedures, so most trainees do undertake either 1 or 2 years of fellowship. And as you know, the fellowships are either from orthopedic or neurosurgical backgrounds. This means that individuals have a difference in the residency competencies based on whether you come from either of the two training backgrounds. Canadian studies have shown that procedural competency expectations during residency have declined in recent time. And CSS, which is the Canadian Spine Society, developed a consensus-based syllabus for competencies and essentially self-reported outcomes for those undertaking fellowship and not. So, what they wanted to look at here was, if you came from a neurosurgical or an orthopedic training background, was there a variation in your knowledge base and your competency or your comfort in certain surgical procedures? And then what they wanted to key on is whether or not there were some key focus procedures that people perceived were necessary that they should learn during fellowship. So what were the study objectives? We're determining the perspectives of the 2015-2016 cohort of AO Spine Fellows and the importance of goals in their training, and secondarily determine their self-perceived procedural confidence at the time of fellowship. So they essentially ask them the same set of questions at the beginning of fellowship and then later on to see whether or not they believe that their confidence can increase and whether or not they're receiving the appropriate training. So with regards to the study design, the questionnaires were administered to 68 clinical fellows under that academic year. It was actually, I went through the paper itself, and there's actually 18 pages of questions, which is 97 questions in total. They did use a Likert scale to quantify training perspectives on the importance of specific procedures during their training experience. And they had 53 general and 22 focus or advanced procedures. And then again, as I indicated, they looked into the trainee's self-perceived confidence at the beginning and at the end of their program. And this is just a snippet of the first page of the questionnaire. With regard to the data analysis, they used SAS 9.3 for their computing data. They looked on clinical relevance, importance, and confidence scores. And they saw essentially whether scores were deemed to be a high versus low confidence. Questions with high importance but low confidence were tested to determine whether it's significantly different from those essentially statistically different, or whether or not it had any importance from that regard. And then the effective length of time in training during residency also played a point. So whether or not something was deemed important or not was taken into consideration. And then they looked into whether or not these individuals had undergone more or less than 6 months of training in spine surgery. And this is obviously important for our colleagues in orthopedics who, at least at the University of Toronto, is only a 3-month rotation in spine in their entire residency. So with regards to the results, this is just some demographics. So there are 68 fellows in total with 82 response rates and 70% completed all the requirements. The follow-up response rate was 69%, so 47 of the fellows completed the end of the review. The mean age was 32.9 years, majority being male. The fellows were mostly in North America, primarily in the US, and 12 from outside North America. And the important part to note here is 77% of the fellows were actually orthopedic trainees, and only 23% were neurosurgical trainees. And this plays into a little bit of our discussion later on. And then again, just looking into how much training these individuals had received, 86% were going into their first fellowship, was about 10% were going into their second fellowship. 4% were going into a higher level of training. So with regards to their confidence and exposure, there's good concordance noted between the syllabus items and fellows' perceived importance. So essentially, they went on to all the items, and obviously, if you've looked into the paper, they looked at the different types of procedures and whether or not the fellows believe those were important for their training. Procedural confidence had a greater spread over the Likert scale, and there is a significant variation between the confidence between orthopedic and neurosurgical trainees fellows. So that's as to be expected given the amount of time that neurosurgical trainees spend on a spine rotation versus the orthopedic spine. Things, just to give an example of some of the different things they looked into: upper cervical instrumentation, sublaminar wiring, odontoid screws, and revision decompression of the cervical spine were found to be highly important, but low experience throughout the fellowship. So, this is a topic where, we've discussed as fellows, and when we see interesting cases that we talk about that we don't see often, but we do believe are important in our training, these were at least deemed by those trainees. And here's just an example of some of those things. So I just highlighted some of the procedures which were deemed to be highly important and low confidence. So, working in the upper C spine, C1-2 arthrodesis, different types of osteotomies, such as cervical osteotomies, were deemed to be extremely important, but unfortunately, we do not get significant exposure to them. And, if you pull our current trainees, you'd probably have a similar experience where these procedures don't come up often, and when they do, most of us, want to scrub in and have a look. So this is looking into the variation in residency. So greater residency exposure to spine was found to be correlated with greater procedural confidence. So fellows who had less or equal to 6 months of already experience, there's 26 fellows, 24 fellows had greater than 6 months experience. for individuals who had up to 6 months of training, they had essentially on a scale of 1 to 5, was a 3.6 in terms of their confidence in these procedures, whereas there's a significant increase in those individuals who had a longer training period during residency. So you can see most rated a 4.8 versus a 3.6. And then similarly, the overall perceived confidence score increased from the initial time, so that's at time 0, beginning of fellowship, versus win time at the end of fellowship. So again, people who had longer training, more than 6 months of residency spine training, were more confident in these procedures. And this was statistically significant. And then the overall confidence at the beginning of fellowship increased throughout the training. Just with regards to a general discussion before I open the discussion, these are kind of like some tidbits. The pros of the study, I believe that the aims were clearly identified and they were appropriately investigated based on the survey provided. They did have an excellent response rate and follow-up, given that they had almost 70% response rate at the endpoint. In terms of limitation, it is a significantly small sample size. So it was only 68 trainees that were surveyed, and that's over only a single year period of time. I think longitudinal data would be important to see whether or not individuals did believe that the training during fellowship maybe equates into what they see in practice, or if it provided them the appropriate tools for that. And finally, the fact that this is data that is self-perceived based on confidence or performance may skew the information. So there's no objective measure for the perceived confidence or the perceived competency of these individuals, such as a third person or a staff assessing their competence in the procedure, something as simple as a decompression. So I believe that is the limitation. And I'll open up the floor to discussion before we get into the other presentation.
Yeah, thank you, Ahmed, and just hats off to Albert and to Jeremy, and also the collaboration with the Vancouver colleagues and the CSS around this. So this was kind of a part of an initial effort to kind of develop some core competencies. And Albert, if you wanted to maybe comment a bit further on kind of that process and around these core competencies that were kind of established.
Yeah, I mean, I think, this is where, as, fellowship supervisors and educators, is really critically important for us to sort of have sort of feedback and iterative feedback, and, sort of recognizing that there's sort of just one cohort of fellows, and just surveyed, obviously at the beginning and the end of fellowship. One of the things that we had done sort of previously, and some of the data is not surprising, obviously, you have a little bit more exposure, you may feel a little bit more confident. Some of the competencies, which is basically based off the curriculum map that Jeremy had led the Canadian Spine Society through in developing. We had also previously surveyed sort of fellowship supervisors, and obviously some of those competencies are generally felt to be a little bit more important than others to know by the end of your training. And it's good to know that some of the supervisors, as well as the trainees in one of the other papers, actually had sort of similar perspectives on which were important. Things like, being able to manage an incomplete spinal cord injury and thoracic trauma was considered to be, highly important, and there's, good agreement on that. So that's reassuring in terms of, I guess the focus for the education. This paper, I think, was very helpful in that it also helped identify those procedures at the end of training where folks still felt, it was important to know, but maybe they weren't as confident as some other procedures. And I think that presents, the tremendous opportunities to sort of bridge that gap through a variety of sort of multi-pronged sort of strategies. So, I think, Steve Lewis, organizes a terrific surgical skills labs for us. And, some of these more complex, for example, upper cervical and other types of cases, which, depending on your context exposure, may be either less common in exposure and experience, or or is just by virtue of the complexity of the case highly important to know, and more exposure is required. Sort of helps us to focus those opportunities for those sort of interesting cases. So I think for the supervisors, it's important, just obviously you have some of those important cases to make sure that you're, reaching out and engaging all the fellows that are part of the program to attend and participate. And likewise, surgical seal courses and maybe even other simulation AR, VR technologies can be sort of built around some of the cases and competencies that I think are sort of important.
There's a question in the Q&A from Dr. Elsa Harden. What are your thoughts on the fact that it's AO Spine Fellowship? Is it applicable to Canadian training programs? Well, the answer is yes. So AO Spine North America includes both the US and Canada, and there are US and Canadian perspectives that were incorporated in terms of this document. And in fact, after this document was created, Albert and I had an opportunity to present to AO Spine North America. And so a lot of the some of the principles, in fact, have been incorporated also into the AO Spine North America curriculum. I see Jeremy, I think you're here, Jeremy LaRouche. I just wonder if we could maybe ask Jeremy to comment briefly as well.
Sorry, guys, I have to be added as a panelist so I can talk. Can you guys hear me okay?
Yes, I can hear you well.
Perfect. No, again, I find myself with the kids in the car, so you'll excuse me if I've got my camera off. They're saying hi. But Ahmed, to your point, I do agree with you that it's a survey which is asking the respondents what they feel is important when they feel is missing. So there's a different aspect of the continuation of the study where initially we asked all the fellowship directors to rank what they felt was important. And then this is the follow-up where we actually ask the people who went through the training saying, after a year, where do you see your deficits? And it's not to penalize an academic or community program. It's probably more to form things like courses or shared learning experiences, for example, at a Canadian Spine Society or an AO Spine course to say, hey, we're aware what the recurrent deficits are in people's training, and these are the ones that we may be able to address in a more specific national or international level that we may not get on a day in, day out basis. But there's always room for improvement, and maybe it's time for us to look at this as another, repolling a new cohort to see if they're still the same or if people have evolved their curriculum.
Very good.
Thanks, Dr. LaRouche. And do you think, to the point of both Dr. Spelling, Dr. Yee, the role of maybe a standardized, I know you've worked a little bit with VAR, whether or not that'll play into it in terms of an objective standpoint of measuring competency, or even, scheduled ITER, just to have a look and see whether or not individuals believe that we can have an objective scale of whether there's an improvement in training function?
Yeah, I think, there's lots of different ways to measure competency or even define what competency is. And I think it's an ever moving target. But what I would lead you to look at is some of the work that Dr. Yee's done in terms of going to the Royal College and saying, well, now that we know what a curriculum should look like, maybe we should be trying to objectively get a diploma for it. So that's in the works. And I think that's something that in the next few years, you might start seeing more as a way of recognizing assessment and competencies. And I think that Canada's going to lead the way. So I'm excited to see what happens.
Very good. Well, good comments. So, and Ahmed, you had another paper to briefly discuss?
Yeah, so it's not a paper. It's actually an abstract that you, myself, and Dr. Yee and Nadia have been involved in looking at the TRES data. And I think that'd be nice to just kind of comment on it and go into. So I'll just share my screen again. One second here, my apologies. Okay. So, kind of in keeping with this myself, Dr. Yi, Dr. Failings, and the team at Sunnybrook, including Dr. LaRouche, are looking into essentially a standardized surgical case log. So any one of our fellows is aware of this. The TRES data that we're need to input all our procedures. So this essentially is looking at the case log as kind of a pilot study. So this is an abstract which I've submitted to both CSF and the COA, and we'll go through some of the data. So the use of standardized surgical case log to document operative exposure for competencies. And it's a citywide, obviously, a university-wide initiative. So as I indicated prior, spine surgery fellowships includes both neurosurgical and orthopedic trainees, and it's increasingly undertaken in preparation for career in spine surgery. All the fellowship programs that I'm aware of are aiming, as Dr. Yi indicated, for standardization of exposure to ensure the competency of our trainees. And right now, there's, outside of the group with CSS, obviously, there's a paucity of data looking at the competencies required and the exposures of trainee, looking at the spine fellowships in Canada. So as you all know, we do have the TRES logbook. So this is data looking from 2015, from when the logbook began, to 2022, so beginning of this year, for all of our trainees. And obviously, as you know, it includes all 4 hospitals. I think the logbook became mandatory in 2018. So the data is a little bit sparse in the first 2 years, but does become more robust later on. In terms of results, there's over 9,000 cases logged with an average of 1,300 cases per year. And as I indicated, more cases later on during the recent years. Over 50% of cases were either performed or at least logged from Toronto Western Hospital, with 29% from Sunnybrook, 20% from St. Mike's, and 5% at Sick Kids. Diagnosed at time of surgery were either degenerative or inflammatory in the majority of cases, around 58%. We did have quite significant amounts of deformity, tumor, as well as traumatic spine injuries. We had, as you can see, a very low amount of cases involving the occiput, and this kind of is in keeping with what I mentioned before, that, you know, upper cervical and occipital trauma and injuries, or even rheumatological disorders requiring intervention, have decreased and are quite rare. So only less than 1% of our cases actually were noted to be involving the occiput. About 26% involving the cervical spine, subaxially, 22% in the, in the thoracic spine, and 46% in the lumbar spine. The most cases logged by a single trainee over their academic time was over 200 cases, with an average of 77 cases per year. So here's just some illustrations looking at the amount of cases logged every year, and then looking a little bit based on hospitals. So as you can see early on, 2015, this was before it became mandatory. And you can see as we've kind of progressed in 2022 can be excluded for the most part, since we're just beginning this year. But 2021, from essentially 2019 and 2021, have a robust amount of data with, you know, between 1,700 to 1,900 cases in every single year. In terms of the anatomical location, again, this is just going into a little bit more breakdown of the data that I already described. So you can see here that the majority of cases do involve either the lumbar or cervical spine, with thoracic spine being pretty close, but primarily the cases are being done in the lumbar spine, which is kind of in keeping with a lot of the studies. And then if you look at Sick Kids, obviously a lot of their cases are more whether AIS or syndromic scoliosis. So you see that the majority of their cases are actually thoracic in nature. So in terms of discussion, the use of a standardized case log can be an effective way to document trainee exposure and procedural competencies during fellowship. These documented exposures are becoming more and more important as they're becoming requested by hospitals during the credentialing process for surgical privileges. Case logs are one of many methods which are accepted for capturing training exposure at the Royal College level, and this will actually allow us to become accredited and prove our accreditation to the Focused Competencies Diploma pathway. And then this data can actually be leveraged, as Dr. Yi said, into curriculum opportunities. So, you know, as he indicated last week, we had the course with Dr. Lewis. We were able to do various osteotomies, cervical exposures, C1 exposure, occiput plating, which we do not see quite often in our fellowship. And this, by presenting these case logs, we'd be able to leverage what needs to be done and the different procedures that may require alternate ways to expose them, whether that's virtual training, cadaver courses, or remote courses. I'll open up the floor for discussion.
Yeah, thanks for the summary. I think this is kind of highlights the importance of documenting the cases, and it will be, it is now kind of required for all of the fellows to provide the case documentation for us to kind of issue the certificates from the university at the conclusion of the fellowship. It's also like really helpful when you're going to apply for jobs, because many places actually want to see evidence of your experience during fellowship, and it'll also be a requirement at the Royal College level to show this. And yeah, so thanks for that. And no, Albert, if you have any other comments.
Yeah, no, I mean, I really need to thank one of our former fellows, Tony Bateman and Jeremy LaRousse. They, along with Nadia, helped to put together basically the case log, which was extrapolated from the CSS curriculum document. And it actually puts our university in very good position as it relates to the evolving Royal College diploma. Apart from sort of hospitals asking for this information, when the diploma rolls out, there's going to be, it'll be a little bit different than at the residency level. The residency level, you have things like EPAs and other types of assessments. The fellowship level is sort of recognized to be a little bit different than some of the base training that you obtain during residency. And so the various inputs are going to be things like copies of OR notes or informed consent discussions and sort of case log type of data as part of that. So I just want to thank all the fellows, really, because this is data is your data, and it speaks to your experiences. And I certainly think at the end of the year, and when we have those sort of celebrations at the end of the year, hand out the certificates, I think a lot of fellows really at that point sort of reflect on, when Nadia sort of gives them the I guess it's a PDF now versus a printout, but the PDF of their all their cases. It's obviously great to see the type of cases that you've been exposed to, the various supervisors and your various sort of roles involved with some of those cases. When the diploma gets ultimately sort of finalized, we'll sort of envision that whatever the updated competencies, we'll sort of update the case log program accordingly. So thanks again, Nadia and Tony and Jeremy, and also to you, Michael, for helping to link us with AO Spine North America for some of the work.
Thank you. Albert, did you want to perhaps introduce the next speaker, who I believe is a fellow at your unit?
Sorry to interrupt, Dr. Fillings. We did have a question, and this probably be better for one of the staff. So Fabio Van Faber Castell is asking whether these numbers are in keeping with OR numbers.
Roughly. I think the numbers largely reflect the activity, but I wouldn't say it's 100%. So I think that, I think it's probably about 80% accurate. But I think that, we're trying to get to kind of the, the higher level. So I think it's a reasonable reflection in terms of what's done. It clearly it's not 100%, but we're aiming toward that now. So we kind of have evolved where it was encouraged, and now where it's a requirement now actually to show the case logs as part of the criteria for graduation.
Yeah, it really highlights what we need to do, and like for our courses and things like that, where people aren't getting experience and what kind of things we have to plug in holes. So I think it's the data. And once you take a few years, you can see maybe we're not doing any occipitals, maybe 1 or 2 a year, and then the experience, just as an example, people can brush up on the things that they're not getting experience on. So I think it's really good. And the more years, the more data we collect, and the more procedures we can see we're doing, then the more we can figure out how to plug holes in our training.
Yeah, I agree fully. Okay. Yeah. Yeah.
Thank you,
Thanks. highlighting the question.
So that's why we encourage all the fellows to keep logging their activities every day and not to wait until the last minute. It will be a whole list of procedures that they'll have to enter at the last minute. This way we have accurate and 100% accuracy of the data that we get out of this database.
That's terrific. And so thanks so much, Nadia, Michael, and Ahmed. And so I will segue to the next presenter. And this is Dr. Rajesh Kumar, and he graduated from neurosurgery from the Aga Khan University Hospital in Karachi, Pakistan. He's been on faculty and staff physician in Dubai with an adjunct professor appointment in the Department of Surgery with the Dubai Medical College since 2018. And he's currently a fellow with us here at Sunnybrook with a particular interest in spinal trauma and degenerative spine. So thanks so much, Rajesh, and I'll turn the virtual podium over to you at this time.
Thank you very much, Dr. Yi, Dr. Filling, Dr. Stephen, and Dr. Jeremy Laroche, who supported me out of the box. So I'm going to present, I have two presentations today. And the first one is the article, which was, in fact, Dr. Laroche supported me and he recommended me to present this article. It's a very interesting article. And second presentation, the excellent case, which we performed together with Dr. Albert G, very nice metastatic lesion. So I'm going to start my presentation with a nerve transfer. It's just a minute, I cannot see. 1 minute.
If you can put
Yes,
it on display.
yes, I can. So the nerve transfer in upper extremity following cervical spinal cord injury. It's a part 1. Sorry, 1 minute. Yes. So nerve transfer in upper extremity. It's a spinal cord injury. Part 2, preliminary results of a prospective clinical trial that was performed in US. And I'm Dr. Rajesh Kumar, and thank you very much to Dr. Laroche. The article was published in Journal of Neurosurgical Spine in 2019. So before highlighting the topic, there was the same article, same author published one article, is a part 1. So we have discussed today, we are going to discuss a part 2. Initially, I'm just giving the brief intro regarding about my part 1 systemic analysis. It's a systemic review on nerve transfer to improve upper extremity function in tetraplegia. And the search method was performed from 1996 to 2019. And inclusion is information on clinical details, operative details, and strength outcome of the nerve transfer. And the results were 22 unique studies with 158 nerve transfers were performed. And mean duration of follow-up was 18.7 months, and mean follow-up post-op was 19.5 months. So the main goals were re-innervation or restoration of thumb flexion, wrist flexion, elbow extension, wrist and elbow extension. There are certain limitations. Is the study was retrospective case series with small number, some heterogeneity, and the follow-up duration was also variable. In meanwhile, the conclusion, the motor nerve transfer was promising treatment option for restoring nerve function, and flexor have variable response as compared to extensor response. So this was the brief intro regarding the part 1 results. Now the background is spinal cord injury have devastating consequences for the physical, social, and vocational well-being of patients. It is estimated that every year around 250,000 to 500,000 people around the world experiencing an spinal cord injury, with injuries more likely to occur in young adults and lesser extent in elderly patients above 70 years of age. Patients with tetraplegia are dependent on residual upper extremity function for mobility and activities of daily living. Even small gains or partial recovery of upper extremity function can have a positive impact on quality of life. So the objectives of this article is study is to present early results of prospective clinical trial of nerve transfer to restore arm and hand function in patients cervical spinal cord injury. So the methods, the study's design is prospective, non-randomized, single-arm clinical trial of upper extremity nerve function in patients with cervical spinal cord injury. The inclusion criteria is adult patient above 18 years with ASHA A, B, or C grade, with hand function impairment who fit the international classification of surgery in hand in tetraplegia, classes from 0 to 4. Second inclusion is patient with stable ASIA grade and no evidence of functional improvement after 6 months on motor examinations were considered. And the third eligibility for nerve EMG proven nerve conduction studies were used to verify intact connectivity. It's a normal nerve conduction velocity and absence of denervation such as positive sharp wave and deep wave and fibrillation to paralyze. In the end, and the functional stimulation was used to verify activation in target muscle group, while the exclusion criteria was active infection, active systemic disease, significant joint contractures, or concomitant brachial plexus injury. The duration of the study was from 2015 to 2018, and 153 patients were screened for eligibility. 30 patients underwent clinical evaluation and EMG studies, while 22 participants were subsequently enrolled, of whom 21 patients underwent for nerve transfer.
Rajesh, sorry to interrupt. I'm not seeing your slide advanced, so maybe you were just presenting the wrong screen. Is that possible?
I think you should put it on display and then advance it. I don't want to interrupt you, Rajesh.
Sorry, I'm moving the slide. It's not moving?
No, we see slide 1, and can you go into presentation mode?
1 minute. I'm stopping sharing and then again I'm re-sharing. And is it okay?
You can see your
What I would
screen.
do, the bottom right of the screen, do you see the 100% or whatever, just to the left of it?
Yes, it's
No, to the left, there's a screen button. Nope,
mm,
even further left. There,
yes,
that icon,
yes,
click it.
it's okay.
This one, yes.
Is it okay for you? I'm moving my slides.
No.
Are you able? No.
No.
1 minute. It's slideshow.
Yeah, this one, just click on it.
Yes, I'm clicking. Yes. Is it okay?
If you go to the top and go to slideshow, try to just select the top where it says home, insert design animation slideshow. So go to slideshow. There you go. We see your first slide there. So
if I'm moving the second slide, is it okay?
yeah, perfect.
Okay. So sorry for this issue with some presentation. So now I'm at right track. Is it okay for all of you? Methods, clinical trial. Okay. So is it okay for all of you to see the duration of study and enrollment?
Yes.
Okay, so the study was performed from 2015 to 2018. Out of them, 153 patients were included. 30 patients underwent clinical evaluation, while 22 participants were subsequently enrolled. Out of them, 21 underwent for nerve transfer, and 17 participants with strength outcome and minimum of 12-month post-out follow-up were included in analysis. So it's a consort trial flow diagram, which I can show you in the next picture. The most participants were male. It's 94.1% with a median age of 28.4 years, who underwent for nerve transfer at a median of 18.2 months after a spinal cord injury. The most common etiology is spinal cord injury, which is traumatic, while in one participant, he experienced a spinal cord injury after decompression for degenerative cervical myelopathy. At the time of preoperative evaluation, participants had a spinal cord injury level between C2 to C7, and the most common level of injury is at the level of C4, which is 35.3% with ASIA grades of A through C with international classification hand and tetraplegia trial class range 0 to 4. So this is the consort where we can see clearly the enrollment is 131 patients, while allocation is 22 patients, did not undergo nerve transfer in 1 patient, follow-up, no patient in this study who lost to follow-up, while there was the one death which is not related with spinal nerve transfer procedure. The analysis was in total 17 patients who have followed at least for 12 months. So the intervention and pre-op assessment, the pre-op assessment criteria was very specific, as the multidisciplinary team plan have evaluated all the patients with a separate pre-operative assessment by the study principal investigator, orthopedic hand surgeon, physiatrist, and the hand therapist. And the nerve transfer were individualized to each patient's functional deficit, while the procedure was performed by one attending physician. And the follow-up period was 2 weeks after surgery. Patient began scheduled hand therapy, that is for twice per week for 24 months. This included 1 hour of dedicated hand physical therapy and occupational therapy of motor re-education. So the operative procedure was performed under general anesthesia. And then the nerve transfers, there are total 42 nerve transfers were performed in 26 upper limbs. Out of them, 9 of the 17 patients underwent bilateral nerve transfer, while a combined double nerve transfer was performed in 14 of 26 patients in upper limb, with the remaining cases being single in 42%, while triple nerve transfer in 1 patient, which is 3.8%. To restore finger flexion via transfer of brachialis branch of musculocutaneous nerve to anterior interosseous nerve, flexor digitorum superficialis, and motor branches of median nerve, while to restore wrist and finger extension, they transfer the supinator branch to the posterior interosseous nerve of radial nerve transfers. The 2 transfers were performed concurrently in 13 or 50% of the patients. And the follow-up, the patients were evaluated pre-operatively, and a scheduled evaluation with the post-operative dedicated follow-up 2 months, 6 months, 12 months, 18 months, 24 months, and 36 months after surgery. And the primary outcome measure was post-operative muscle strength as assessed by manual muscle testing, and the secondary outcome measures to include donor muscle strength to make sure is there any loss in the donor muscle. And accordingly, they included an analysis patient who evaluated for at least 12 months post-operatively, with the last available follow-up up to 24 months. So the analysis was performed by static analysis 24 version, and these were the results, which I can show you here in this picture. We can see this is the pre-op for flexor digitorum muscle. Here there's a significant weakness. On the top, it's written MRC motor strength assessment grade, MRC 1, 2, 3, 4, and this is MRC 4, which is stronger and the weaker. Here in the flexor digitorum superficialis, the initial pre-op score is very weak, which is MRC 1, while there is some improvement with the p-value significant at the end of 24 months or final follow-up. So there is some improvement in the flexor function as well as flexor digitorum. Same way in all pictures we can see in the graph, there is some improvement in the power in the upper limb in the flexor compartment, and there is a little bit better improvement in the flexor carporadial wrist flexion in this group with a power of 4. While in the next picture, in the next slide, in the extensor, there's a slightly improved, better function as compared to the flexion, which was even in the preliminary study 1 results. So there is a significant improvement at the level of extensor carpi radialis brevis function, some improvement at the level of elbow extension, while there is some movement at the level of wrist extension, and there is some improvement at the level of extensor digitorum communicans. So this is the improvement, Michigan Health MHQ total combined score for affected hand as well as DASH score. So the results, there are 17 participants with a median age of 28.4 years who underwent nerve transfer at a median of 18.2 months. The range from 5.2 to 138 months after injury were included. The patient who underwent transfer to median nerve motor branches and completed 18 and 24 months follow-up achieved some finger flexion strength medical research council grade more than 3/5 in 4 of 15, that is 26.7%, while 3 of 12 treated upper limb respectively. Similarly, patients achieved MRC grade more than 3/5 in the wrist flexion strength in 5 of 15, that is 33.3%. and 3 of 12, that is 25% in upper limbs. Same way in extension, the posterior interosseous nerve function for wrist flexion and extension MRC grade of more than 355 strength was demonstrated in 5 of 9, that is 55.6%, and in 4 of 7, that is 57.1%. Similarly, grade more than 3.5 strength was demonstrated in 5 of 9 and 4 of 7 cases of thumb extension. So no meaningful donor side deficits were observed. Patient reported significant post-operative improvement from baseline and upper extremity specific self-reported outcome measures. So this is the MRI picture of the supralesional zone of injury and infralesional compartment, and some limitations in the strength of this study. First, it's a single institutional trial of 17 patients with some heterogeneity in clinical characteristics and follow. Second, the procedure were performed by one attending peripheral nerve surgeon, which may limit the generalized ability of our finding. Third, we did not completely account for the influence of patient overall health status and coincident comorbid condition when assessing strength outcome. There are some strengths of the clinical studies are its prospective design, predefined inclusion and exclusion criteria, extended follow-up duration, and assessment of muscle strength by independent reviewer in most of the cases. So the conclusion is nerve transfer provide a promising alternative for intervention in this population. Our experience, the nerve transfer for the reinnervation of hand and the finger flexor showed a variable functional recovery. However, transfer for innervation of arm, hand, and finger extensors show a more consistent and meaningful return of strength and function. So multidisciplinary approach that is focused on individual patient deficits, reinnervation priorities, and understanding of spinal cord injury pathophysiology and motor re-education is critical for the success of nerve transfer in spinal cord injury. Ultimately, a comprehensive reconstructive strategy that additionally combines muscle and tendon transfer will likely provide the best long-term clinical outcomes. And thank you very much. This is all about the presentation. I have one more presentation, so we can first make some discussion. Dr. Yee and Dr. Filling, Dr. LaRoche.
There's a lot of interest in nerve transfers. So this was kind of part 2. Did you? That was published 3 years ago. Has there been any follow-up from this particular group?
I'm happy to help field that. I haven't seen follow-up from that particular group, but we have started our own assessment pathway for nerve transfer at Sunnybrook for acute spinal cord injuries. And I must say, I've been pleasantly surprised with some of the outcomes that have been achieved for a very small subsection of the population. However, that being said, the ones that do qualify and are screened early have had significant clinical benefit from having early nerve transfer. So one of the things that's been new for us, which I think it's been kind of a revelation in terms of how I look at SCIs now, is that we now have a multidisciplinary spinal cord injury assessment center, which is staffed by spine surgeons, physiatry, and plastic surgeons. And anybody who has a spinal cord injury within the realm of anything from cervical up to T1, typically tries to get an assessment within 3 months. And they'll do EMG nerve connection studies on site, and they'll try to assess the candidates that have the least amount of spontaneous recovery and try to transfer nerves early. And the functional restoration of what's been able to achieve specifically for things like finger flexion, wrist extension, and even intrinsic function has been quite remarkable.
Well, there's a lot of interest in the technique. I saw a paper, I don't think from this group, that was also presented at the Cervical Spine Research Society meeting recently in tetraplegic individuals with quite encouraging results. And it's good to see that this program is starting to these techniques are starting to be recognized up here in Toronto. So Jeremy, maybe I can just ask you then, what is the earliest then that patients in your program would be considered for this kind of a nerve transfer procedure? I'm interested to hear that you're evaluating these individuals as early as 3 months after injury. I might have thought that one would wait a bit longer to kind of to see where the plateau of recovery might occur, or are you basing this sort of on the trajectory of the recovery curves?
It's a great question. And the challenge is that if you wait too long, so if we wait after 12 months, the outcomes are not as good once there's been some degeneration of the motor end plates. So it's a little bit of a tricky thing where we're starting assessment at 3 months. The intervention tends to be done between 6 and 9 months. There's a few people that we've done out to 15 months, but beyond that, the outcomes are suboptimal. So what we're looking for is normally at the 3 month, we get a baseline EMG and we'll repeat it at the 6 month mark. And if between clinical assessment, electromyography and nerve connection study evidence, there's no real improvement of the nerves that we're looking to target, at that point, the interventions tend to be scheduled somewhere around the 9 month mark, with a few people that kind of struggle a little bit later on, especially with polytrauma. But the problem is long-term outcomes with delay has not been as effective. And the last thing as you suspect, the last thing we want to do is intervene in someone who would expect to have a natural recovery anyways.
Yeah, a lot of interest in the technique. I think that they've got a pretty significant experience with this kind of local in Canada, at least in Montreal. It's been my kind of my sense, and I do think also that they evaluate people kind of relatively early in the Montreal program for this. Like I said, I saw a presentation on this at the CSRS. So results were looking kind of interesting. I don't know if there are any further comments or questions in the. So I think Rajesh, you had maybe time for like just a very briefly.
Yes.
Be respectful of the time.
Thank you very much. I just try to make it in 7 minutes within my due time. So it's a very interesting case performed by Dr. Albert Shi. Is it okay? We can see this clinical history.
We will need to put it on display so we can advance the slides.
Is it okay, Nadia?
Not yet.
No, not yet.
We're on the slideshow.
Yes, stop sharing. Okay, 1 minute. I'm sharing it now. Metastatic collagen. Okay.
We go.
Slideshow. Okay, is it okay?
So click on the resume slideshow button, Rajesh. You were
Yes.
just try that.
Yes, sir. Is it okay, sir?
No.
Go on top, you see slideshow on top bar between review and animations.
Review and animation. There is a new slide.
On top, just look on top of your PowerPoint.
Yes, I'm. Oh,
The top left, if you bring your icon up there. Yeah. Nope, there should be a slideshow. Sure, try that, see if that works.
no, this is old. So this is my presentation. So I'm here. So slideshow, resume slideshow. Resume share.
Rajesh, yeah, perhaps just out of respect for time, because
yes, sir. Sorry.
Maybe with respect, if we might maybe forego your presentation today and maybe consider this being presented at a different a venue. Maybe we might consider moving forward with Raj's presentation. This is from Sick Kids Hospital, and I think this is going to have a pediatric deformity theme. Raj, are you able to share your slides?
Raj Shekarkar.
If Raj, Sakrakar, are you there? Are you able to share your slides?
Yes, I'm just sharing. Yeah, thank you. This connection.
Okay, yeah, thanks.
Hope everyone can see my screen.
Yeah, looks good.
So I'll be discussing 5 major controversial issues about the fusion levels in section of correct levels in adolescent idiopathic scoliosis. It's a narrative review. So over the decades, the selection of the fusion levels have been changed right from the Harrington era to the modern instrumentation with pedicle screws. Selection of pedicle screw levels with pedicle screws have significantly changed from 1960s because of the maximal amount of curve correction to achieve the main goal to achieve a stable and balanced spine. Also, there is the goal to save as maximum mobile segments, in particularly of the lumbar spine. Choosing the levels has always been a debatable issue. This article chooses 5 major issues to discuss in the article. First issue is selective thoracic fusion. The second is selective thoracolumbar or lumbar fusion. Third is how to prevent the adding on phenomena. And fourth is distal fusion level selection in major lumbar and thoracolumbar curves. Fifth is proximal fusion level selection and shoulder imbalance. We'll discuss it one by one. Considering the selective thoracic fusion, the concept of selective thoracic fusion introduced to correct the main thoracic curves and minor lumbar curves. By definition, selective thoracic fusion means fusion of the main thoracic curve where the minor lumbar curve can be left unfused. Conventionally, it is considered fusion L1 or above. So which are the curves which are fit for this criteria? They are considered King's type 2 and Lenke type 1B, 1C, or 3B. A minor lumbar curve must have completely deviated from the midline is one of the criteria for selective thoracic fusion. So what are the advantages of non-selective thoracic fusion, where we go down and involves lumbar curve also? Well, it gives larger amount of correction and it doesn't have persistence of the lumbar curve and there is no progression of the lumbar curve, but at the cost of the mobile segment. So this is the criteria where the factors of the selective fusion have been discussed by Charles Fisher et al. And I will go one by one. So what are the criteria as factors which discuss the selective thoracic fusion? So candidates which are Lenke 1C, 2C, 3C, and by King's classification 2A are thus ideal candidates. Clinical parameters, patients who have thoracic rotational prominence on scoliometer, like thoracic hump bigger than the lumbar hump, and who are less flexible with checked with the thumb abduction or flexibility index on the clinical and as well as the radiological parameters where the bending out of the lumbar spine goes less than 25 degrees. There are other parameters where AVT, like that is apical vertebral translation by apical vertebral thoracolumbar ratio goes higher by 1.2. So the ratio varies from surgeon to surgeon from 1.2 to 1.5, as we had discussed this with Dr. Stephen Lewis, and his criteria varies from up to 1.5. So this 1.2 criteria is a little variable as per the surgeon to surgeon. Again, the second criteria is AVR, that is apical vertebral rotation, which is checked by Nash and Moore, which we'll discuss subsequently. So the ratio of apical vertebral rotation of thoracic divided by apical vertebral rotation of thoracolumbar or lumbar should be higher than 1.2. And the thoracic Cobb's angle should be the ratio of thoracic Cobb angle by thoracolumbar or lumbar curve should be more than 1.2. Again, the sagittal plane criteria, the kyphosis, the junctional kyphosis at the inflection, the thoracolumbar kyphosis should be less than 10, as well as the sagittal disc angle below the last instrumented vertebra should have a little bit of lordosis. Patient who have skeletal maturity where the prior radiate cartilage is fused, that is clinically they are a little stiff, they are good candidates for selective thoracic fusion. There are additional criteria, like as discussed, to flexibility index, where thoracolumbar curve bends out to less than 25 degrees. So discussing the advantages of selective thoracic fusion, it has greater number of mobile segments. Also, few of the thoracic scoliosis surgeries are cosmetic surgeries. So stopping at L1 gives a shorter incision in young patients. Also, it has shown that this degeneration, if a patient in the long term, has found to be less when in terms of selective thoracic fusion. So this is one of the cases discussed in the article where the surgeons have fused selectively the thoracic fusion from T3 to T12, and at the 4-year follow-up, the lumbar curve tends to be stable and gave good clinical and radiological outcomes. The disadvantages of selective thoracic fusion vary from decompensation, add-on phenomena, persistence of the lumbar curve, or progression of the deviation of the trunk. The good outcomes have been shown in various literature, shown by Lawson et al. They have shown a 20-year follow-up where the lumbar curve is found to be stable in selective thoracic fusion with AIS patient. Also, a few of the studies by Peter Newton et al. They have shown that there is spontaneous correction of the lumbar curve after the selective thoracic fusion. There are the few studies who are critical about the selective thoracic fusion by Demura et al. And they have shown that about 57% of the patients will have persistence coronal imbalance. Also, Peter Newton et al. Make one mark that 1B curves tend to have more of a preference for the selective thoracic fusion, as high as 92% by the surgeon, in comparison to the 1C curve, which have the preference of 68%. So what are the adverse outcomes for the selective thoracic fusion, as we discussed? First, coronal decompensation in the form of ore, which is usually because of the overcorrection of the thoracic curve in selective thoracic fusion. If the degree of correction in thoracic curve is excessive, the lumbar spine doesn't match with the correction and kinds of results in decompensation. There are strong recommendations to not to overcorrect the thoracic curve. And to ensure the thoracic curve, it has been said that preoperatively, we should check the bendability of the lumbar curve with the push-pull X-ray or the sign-depending X-rays or the supine and post-anesthesia X-ray. Giving the example, if the lumbar curve is around 50 degrees and bending X-rays, it goes to around 15 degrees, then thoracic curve should be kind of considered to correct till 50 degree and not to 0 degree. So to have a minimal curve, so which will help in not to decompensate the lumbar curve. Again, the second reason to have bad results with the coronal decompensation is inadequate identification of the lumbar curve. So selective thoracic fusion usually should be avoided with the curve, lumbar curves more than 45 degrees, where the surgeons prefer 60 degrees curve. But then again, there is in selection of King type 2A, few of the surgeons divided King type 2A into A and B, and the selected 2A will be the good eye candidates. So overall, to discuss, summarize the selective thoracic fusion, it is for the thoracic major and lumbar minor curves. King type 2 and Lenke 1B and 1C are ideal candidates. It can be extended to 2C and 3C with a little higher risk of risk of decompensation or add-on phenomena. The good advantages are it preserves the mobile lumbar segments. The risk are decompensation, and it can be prevented by preventing the overcorrection of the thoracic curve. Coming to the second point where the controversial issue arises, the selective thoracolumbar or lumbar fusion. Usually, the selective thoracolumbar or lumbar fusion is advised for the Lenke 5C or 6C curves. As we discussed, the curve ratio with thoracolumbar to lumbar curve is, if it's higher than 1.2, it's usually advisable for the selective lumbar curve fusion. Also, closure of the triradic cartilage gives good results considering the stiffer spine. Earlier, the high flexibility of the spine shown good results, but later on it was found that the spontaneous correction, which was seen earlier, didn't give the long-term good results. Also, more flexible spine found to have progression of the curve during the follow-ups in the long term. In controversy to the selective thoracic fusion, the thoracolumbar fusion curves, they advise to have a maximal correction instead of undercorrection, which we did and saw in selective thoracic fusion. It was suggested that it does not influence the coronal imbalance. So this is one of the case where a 16-year-old female was having a Lenke almost 5C curve, where a whole of radiograph is shown. Thoracic curve was found to be flexible on the bending, where it reduces to 12 and 11, and they did thoracolumbar fusion from T11 to L4, and at the 4-year follow-up, they found good results. There has always been a debate about the surgical approach for selective thoracolumbar fusion, either anterior or posterior. The recent article by Dung et al. Has shown that the spontaneous correction of the unfused thoracic curve is comparable between the anterior and posterior fusion during their 4-year follow-up. Also, anterior approach versus posterior approach has always been a point of debate for the thoracolumbar curves. The study done in Beijing they've shown that the surgical treatment for Lenke 5C has shown a greater correction of thoracolumbar curve via the anterior approach, while the study done by Geck et al., they have shown that the better clinical and radiological outcomes have been seen with the posterior approach. So there are both studies where both the outcomes have been shown. There's another review research study where they studied the 7 case control studies where both the approaches been studied. So they finally concluded that both the approaches give good amount of clinical and radiological outcomes, but the main point of in anterior approach is that you can save few levels with it. So to take home message is that, and if you do anterior approach, you can save more levels, whereas other clinical and radiological outcomes are same with both anterior and posterior approach. So just to summarize, if you feel the thoracic rigidity, if the thoracic spine is rigid, it's better to extend to the thoracic level. Again, the point to discuss the third point is the adding on phenomenon. The adding on phenomenon is usually defined as the progressive loss of correction by the vertebral deviation of the lumbar spine or disangulation below the last instrumented vertebra. The last instrumented vertebra has always been the important factor in the development of the adding on phenomena. And one of the studies has found that the adding on phenomena is found to be more when the preoperative last instrumented vertebra, which was planned, +1 has deviation from the center sacral vertical line of more than 10 millimeter. This is one of the case where the distal adding phenomena has been shown, where a 13-year female, the Lenke type 1B curve, showed an adding on phenomena. It's the factors could be many, but the last instrumented vertebra should have been little down, but they had stopped. So at the end of the follow-up of 4 or 5 years, they revised it and extended to L3 and finally found the good results. Just to describe in small details, the end vertebra, as pointed here, is defined as, for the further slides, end vertebra is defined as the most util vertebra. The neutral vertebra is considered the neutral rotation vertebra with pedicle asymmetry, and the stable vertebra is considered the most proximal vertebra with the distal to the end vertebra and the in end vertebra structural construct, and is nearly bisected by the centrosacral vertical line. It will help in the next slide. So in this slide, the T10 is the end vertebra, T12 is the neutral vertebra, and L2 is the stable vertebra. In this case, the surgeon has stopped at T11, just one minus to the neutral vertebra, and after a few years, there was add-on phenomena seen. In the other case, where surgeon has stopped at T12 at the level of the neutral vertebra, and it has shown good clinical and radiological outcomes. This is the article discusses. So how to prevent the add-on phenomena? So it has been shown that the Lenki A curves, they divided the Lenki curves into 1A left, the left variant, and 1AR right variant. And they discussed that if the opening of the disc at the L3-4 disc is more towards the right, then there is less chance of add-on phenomena in this patients. If the disc opening of the L3-4 is more on the left, then there is 2.2 higher chance of add-on phenomena in this patient. So if you have the AL variant, they are advised to go to one level below. So again, the same point to continue, the distal fusion level where to stop in major lumbar and thoracolumbar curves, either at L3 or L4. The few studies have shown that the pain intensity where the last instrumented vertebra was L4, the pain intensity in the patient was found to be more in comparison with the patient where the last instrumented vertebra was L2 or L3. Also, a few of the studies have shown that the advanced disc generation happens when the last instrumented vertebra is sore in comparison to the L3 or L2. Think in 1993 given few criteria when the fusion level should be at the L3. So the first criteria is the less than grade 1 rotation at L3. The tilt of L3 should be less than 30 degrees. The L4 vertebra should be bisected by centrosacral vertical line, and the apical disc in the thoracolumbar lumbar curve should be above L1 and L2. The direction of the opening of the L3-4 should be parallel or opposite of the L4-5 disc, and the direction of the location of the L3 should be centered on the bending films. It was the Lenki's criteria were a little complex, so it was possibility of application was difficult for the surgeon. Then Kim et al. Gave another criteria, simple criteria, where he said if the L3 rotation on the national grade is 2 or less than 2, then L3 should be sufficient to fix. And when L3 is more better criteria when the curve is more flexible and when the centrosacral vertical line crosses L3 on the bending films. Also, a few of the studies I mentioned, if under general anesthesia, if L4 kinds of with traction straightens out, then you can stop at L3. Also, there are a few criteria mentioning about sacral slanting and lumbosacral transitional vertebra. If the S1 is kind of sacralized or L5 is sacralized, it's better to stop at L3 and keep more mobile segments. So this is the example of one of the studies where L3 on bending is kind of gets straightened out, both the pedicles are straight on the bending films though. So in this case, the surgeon stopped at L3 and it has finally gave good clinical and radiological outcomes. However, after a few years, patient had mild wedging as well as add-on phenomena, but it was not clinically affecting the patients. So few of the studies have shown that even with L3, even if you stop at L3 and if there is add-on phenomena, the clinical outcomes doesn't vary much, although the radiological outcomes vary. So studies by Ding et al, they have shown stopping at L3 or L4 doesn't matter much clinically. Kim et al has shown, as we discussed earlier, L3 can be last instrumental vertebra if L3 is flexible and crossed by CSVL. There is, so in summary, to discuss the distal fusion or L3 or L4, the clinical advantage of stopping at L3 is unclear as a few of the studies recently, but it importantly saves the mobile lumbar segments. The radiologically subjacent disc wedging is a problem in long term, but comparative and long term studies have, few of the studies have shown better outcomes when we stopped at L3. Again, to discuss the last point about the proximal fusion level selection and shoulder imbalance. So inappropriate proximal fusion level has shown a poor outcomes of shoulder imbalance as thought in earlier studies. In 1993, Lee et al proposed that both proximal thoracic and the main thoracic curve should be fused. The left, and they also proposed if the left shoulder is high or elevated, then and if the proximal thoracic curve is rigid, it's always better to include the proximal thoracic curve with the main thoracic curve. Otherwise, the Lenke et al proposed that even if patients have the elevated right shoulder, and then proximal thoracic curve is usually not required. So in these cases, they have mentioned if the proximal curve is between more than 30 and bends out to 20, then it can be left alone. And you can just fix the main thoracic and you can skip the primary thoracic. The Suk et al also recommended that both primary thoracic and main thoracic curve fusion in patients with proximal thoracic curve of more than 25 degrees and with a balanced or elevated left shoulder. A non-fusion strategy of proximal thoracic curve has been advised by few surgeons between 35 to 45, and they believe that there will be spontaneous correction of the proximal thoracic curve. Also, they advise that the reduced correction, as we discussed in the selective thoracic fusion, that the reduced correction of the main thoracic curve will helps in the spontaneous correction of the proximal thoracic curve. A few articles have mentioned reasons to go higher than T2 or T3 levels. They mentioned that first, the going higher will give rise to cervical problems, most commonly like proximal junctional kyphosis and cord changes in the proximal levels, junctional levels. Also, secondly, the upper surgical skull is stressful in teenage patients. The spontaneous correction of the proximal thoracic is frequently found in most of the studies. Also, shoulder balance was found to occur despite the selection of the correct upper instrumental vertebra by several methods. Also, they have mentioned that T1 tilt is not likely to be related to the shoulder balance. Few studies recently have shown that the clavicle chest angle difference could help in determining preoperative and postoperative shoulder balance, but other studies have disputed their results with the clavicle chest cage angle difference. Also, few recent studies have shown that the shoulder imbalance is a subjective issue. It's very commonly seen in normal population with having a shoulder imbalance. And even though clinically patients will show radiological imbalance, but there will be a good clinical balanced shoulders. So there is always a gap between the radiological and cosmetics aspect in the shoulder balance levels. Coming to the limitations of this study, we have discussed all the 5 major controversies. And coming to the limitations, well, it's not a systematic review. The evidences shown, the opinions and the studies discussed were always debatable. There were studies on both the sides. Pros and cons of the both studies have been explained. There is definitely a paucity of high qualified and relevant studies. Although the study helps to provide the current concept about the fusion levels in the AIS. So to conclude all the points, the selective thoracic fusion and selective thoracolumbar or lumbar fusion can help to reduce the number of fusion segments. Careful selection of the patients and the fusion level is critical to avoid complications such as coronal decompensation or add-on phenomena. There has been no consensus about the appropriate selection of LIV or UIV in current literature, though we need good validation studies to address these controversial issues in the future. Thank you.
Thank you very
Thanks, Raj. Yeah, I think
much.
you know, anything where you need 27 rules for one little thing is always difficult. And it just shows the controversies and the lack of clarity in conditions. I think there are some basic principles that you have to stick to. And basically, if the curve is structural, it most often has to be done. And then selective fusions in immature patients are unpredictable because of continued growth. So those are the kind of the things that we were doing. You know, whether we can do selective fusions. I think there's a lot of controversy because the way people correct it is different. And so what maybe some people can get away with, some others can't. I can tell you selective fusions where you do a half correction on the thoracic spine, most of the patients really aren't happy with that. And to leave them with a big bump in their thoracic spine because you're trying to save a curve that should be included in your fusion is really probably not the objectives of most of the curve correction. So I think there is a lot of controversy and there'll always be controversy. And I've been to meetings for the last 20 years and we always have the same discussion, whether you should stop at L3 or L4 with the shoulder balance, when to go to T2, and no one's getting any smarter. And that I can promise you. So there's a lot of controversy. You do what works for you. There's certain principles you have to have and you should stick to them. But I can tell you that most likely, if it's structural, you should probably think about doing including it in your fusion in most cases. And if you don't, you can just warn the patient that it's not as predictable and you may require another surgery down the road.
So Steve, is there a significant, like I get that you're trying to reduce the number of levels in the lumbar spine, but from a practical perspective, is there a big functional difference between stopping at L3 and L4 and kind of what do the long-term follow-up studies suggest?
You know, that's the problem is because do you leave 3 crooked levels or 2 straight ones, and which one's better? And I can tell you that I see a lot of Harringtons 40 years later that are done and you want to vomit and they still did quite well for many years. So it's really, I think it's a lot of multifactorial. And we think that if we have them properly aligned, it's better. But if you leave a crooked lumbar spine, it's not going to wear as evenly as a straight one. And I would say that, you know, on my when it's controversial, when it's not controversial, it's easy. I should probably stop at L1. It's probably better than stopping. But if you question of 1 versus 3 to make them straight, I think it's a short answer. And I usually take the longer one. 1 versus 4, I have a longer talk with them. So. But if they really want to be straight, it doesn't make sense to leave them with a big curve. So that's something that we have to individualize each one. We do try to save lumbar spine. A straight lumbar going to L3, I think, is better than a crooked one stopping at L1. So there's a short answer.
There's a question in the Q&A. Maybe Raj or Steve, you could have a look at this. Maybe Raj.
Yeah, sure.
Any use of basically they're kind of talking about assessments of the shoulders, and you know, how do you do this intraoperatively, and then kind of look, does the T1 slope help you at all in this kind of decision?
Yeah, so the shoulders themselves are actually useless because where they put their arm, and the T1 slope and the first ribs is really the key radiographic parameter. So you can tell right away. And even on the one that Raj showed that was successful, had a very high left rib, first rib, and the tilted top. So I think I agree. The shoulders is a misnomer, and really you should be looking at the tilt on one and the top of the first rib. So a good point.
So I guess maybe I had a question for Raj. I mean, thank you very much for a very
Sure.
a detailed review of the current concepts, and I guess having had a chance to sort of review the current opinions and literature, how has this sort of changed your thoughts in terms of how you may approach, I guess, patients and their families? I think, some of the questions in terms of, what's being proposed is sort of, what's the risk of issues down the road and how soon may that happen? And am I going to need a revision surgery at some point and so forth? So I guess any thoughts on that?
Well, again, like I'm under training with Dr. Steve Lewis. He always gives ask the patient what they want, and depending on the patient's demands and exactly all the current knowledge we have, depending on that, we finally give the plan whether they want stable, just selective thoracic fusion, or they want a straight spine to include the lumbar curve, or if there will be future add-on phenomena, they want the revision surgery in future, or they don't want a future surgery. So depending on their demands, lifestyle, if any of the patients have an active lifestyle, if they are doing a lot of sports or have a job which demands flexibility, then in patients selectively we give the only selective thoracic option. If the patient wants that we don't want any future surgery and we don't want any risk of the surgery in the future, and it's okay for them that they are having sedentary lifestyle, and just so we can stop at go down and fuse little below. So these are the usual things depending on the patient tailored treatment options we give.
We never promise them that's their only surgery, first of all. So
yeah,
and Raj, no one has it harder than Raj, who has to see three different things, the same thing, three different ways, a complete confusion. And it's incredible how he'd be able to even figure out what levels to fuse on any of the cases. So but congrats. It's a little difficult because everybody's correction techniques are different and philosophies are a little bit different. But I think there is controversy. When there's controversy, should involve the patient, like he says, and then and make sure that everybody, successful surgery is when you meet or exceed the patient's expectations. So setting the expectations appropriately is a key. So
yeah, very, very, very good. Well, congratulations to all three presenters in great, very varied discussions and topics. We'd be interested in the feedback. Rajesh, it's unfortunate we had some technical issues. Maybe if you just could present your case very, very briefly. And, for those that, wish to sign off, it's completely understandable. We recognize that, that it is, 7:30. So, you may wish to join your families for supper or whatever your plans are, but maybe like 5 minutes, just very, very quickly, Rajesh, if you could. And then for those that wish to stay on, please stay on. And those that cannot, we wish you a good evening.
Yes. So this was really a very interesting case regarding this middle-aged female. She was 53-year female, which was seen on 8th of October with history of neck pain associated with some left arm radiation and some intermittent paresthesia. She just started her symptoms 3 months back with some neck pain. She denies for any hermit sign, bowel bladder dysfunction, any weakness or gait instability. In the past medical history, she have a metastatic cervical spine lesion since July 2022. Otherwise, she was operated for laparoscopic cholecystectomy on 10th of April 2018 with biopsy proven cholangiocarcinoma. Then she was treated with chemotherapy. On 7th January 2019, she had underwent for another procedure, that is diagnostic laparoscopy with subcostal incision with completion cholecystectomy and in-block resection of segment 4 and 5 of the liver. And then she was on other medications, hypertensive, family history is positive for mother with colon cancer, breast and thyroid cancer. And otherwise, she's an ex-smoker, she drinks occasionally. So examination, intact higher mental function, neck examination, mild cervical tenderness, upper limb examination 5/5, sensory intact, Hoffman negative, plantar downgoing. And the plan is on the basis of clinical condition, she have a metastatic C2 lesion. We decided for workup, CT navigation, MRI with contrast, medical oncologist, radiation oncologist referral, and then plan for surgery with long discussion with debulking and stabilization. So this was some MRI. I don't know we can see or not. We did first MRI was done on July 5th, which was significant metastatic lesion at the level of C2 with significant compression, mild compression at the level of C2 with osteolytic bony lesion. On the CT scan, we did the CT scan, it showed complete osteolytic lesion on the right side C2 with involvement of C2 posterior lamina and lateral mass, pedicle, distortion of the pedicle. So and then there was some bone scan which showed some metastatic lesion at the level of left ear, 10th rib, and the C2 lesion. So this was a follow-up MRI which shows significant expansion of the lesion with more compression and more instability. So on the basis of clinical condition, the CT scan was repeated, CT navigation was done, and we decided for surgery under prone position with careful positioning, Mayfield head clamp, neuromonitoring, C-arm, navigation, and we decided for procedure for C1 to C3 decompression, followed by occipital, cervical, posterior stabilization, posterior extradural decompression of metastatic lesion with left posterior lateral C1, C2 region and for excision of the lesion. So this was the intraoperative OR images. So she underwent successfully for surgery and intraoperative. As I was a part of surgery, the good thing was lesion was not highly vascular. So it was a well-defined capsular lesion with significant, the lesion was more than 5 centimeters. So we decompressed almost, it was subtotal resection, except we left the anterior part, which is extending anteriorly to the C2. Otherwise, we removed most of the tumor, and then we did occipito cervical fusion occipito, and then C2, C3, C4, C5 fixation. Post-operative course was excellent. She remained well with no new onset deficit. She was mobilized, in fact, after 48 hours of surgery, and the histopathology reported as a metastatic adenocarcinoma. And she followed recently last week in our clinic. We did the X-ray that showed very nice fixation with complete stabilized normal implants. And this was a follow-up. So Dr. Yi was he was a staff physician, so I just want his comment. So it's a cholangiocarcinoma with a very bad prognosis, but the prognosis can be improved if we did the decompression, and we did the nice radiation oncologist referral with the oncological management, so we can extend significant survival in these patients. So this was a patient, and Dr. Yi, I just want your input.
Yeah, so I think it was just an example of a case that sort of complemented, some of the journal article discussions about, some of the upper cervical procedures. And, I think with these types of procedures, the setup is about 90% of the operation, so that you basically have your navigation, your imaging, and all your equipment and your team sort of all prepped and ready to sort of proceed to do things efficiently and safely. The challenge with some of these, and I still struggle with it with some of these metastatic lesions, is some of them can be quite vascular. We know those that typically are sort of renal, thyroid, and those that you may sort of embolize in advance. But having said that, there are some spectrum of these sort of tumors, and some can still be quite vascular. And the other aspect sometimes that can be a little bit challenging as well. Some tend to be a little bit more adherent to dura, and the decompression can be a little bit more challenging to ensure that you can get rid of the sort of epidural disease, because that's the one area that the radiation therapy, and even with things like SBRT, has a bit of a challenge in terms of addressing the epidural disease a little bit more specifically.
And I think just a quick comment, if I may, I think there's two components to the SBRT. And number one is the epidural disease, and number two is the size of the met. So in these cases where there's a very large lesion, having a very excellent resection like this has been done, where you can debulk the met, also has a significant benefit, which makes the radiation much more effective. So I think this is a really good surgery in a tough case, and I think the results look fantastic.
Yeah. Fortunately, the lesion wasn't very adherent, and it was able to be sort of decompressed fairly readily, and was quite well encapsulated, as Dr. Kumar had mentioned. So the exposure into that area, obviously just making sure that we're not providing any pressure as we're, exposing down to the spine, was quite straightforward.
There was a question, was there any vertebral occlusion testing preoperatively? And maybe I'll just kind of broaden that. Did you consider the option here of kind of a CT angiogram potential, or any kind of embolization of lesions is something that you might have thought of? And can you maybe just, Albert or Rajesh, maybe just talk a little bit around the assessment of the vertebral artery anatomy preoperatively?
Do you want to comment, Rajesh, and then I can?
I think better, Dr. Yee, you can comment.
Yeah, so that's an excellent question. I think the issue is sort of asymptomatic. The CTAs can certainly be helpful. I guess I've had some varied sort of feedback in terms of embolization up in and around that area. So it's a little bit nuanced, and sometimes it's able to be done, sometimes it's not sort of able to be done. In this sort of situation, we basically have that sort of discussion and dialogue with the RadOnc and the MedOnc team. Certainly if it was something like renal or thyroid, absolutely, I would have asked for a more formal interventional opinion approach on those. But sometimes they're able to be embolized, sometimes they're not. With the decompression, our main focus primarily was that left side of the cord, and just sort of being cognizant of where the vertebral artery would be, and not entering into that area specifically.
Yeah, good point. Well, I think maybe given that we're a bit over time, maybe we should kind of call it an evening. And thanks to all the presenters for some excellent discussion. And Nadia, thanks for helping to organize this. Do we have a date set yet for our next journal club?
Not yet.
All right. Okay. So we'll look forward to that. And, Albert, if you want to make any closing remarks before we call it an evening.
Yes. So many thanks again, Ahmed, Rajesh, and Raj. Really appreciate all the time and efforts, and sharing a wide spectrum of types of spine activities. And I think it sort of showcases a little bit of depth and breadth of expertise in and around the city. I think an opportunity to sort of highlight some of our efforts with the Royal College. I think the diploma program is going to be proceeding quite efficiently over the next year or so. And I think with the infrastructure and the support of folks like Nadia and others, and enablers such as our case log programs and our citywide academic calendar events that includes journal clubs, surgical skills labs, and so forth, I think would be terrific in terms of further advancing, obviously, the educational opportunities for the training of the next generation of spine surgeons. So thanks very much, everyone. And thanks for those participating this evening. Keep well, keep safe, and I hope everyone has a safe and enjoyable upcoming holiday season.
Very good. Thanks, everybody. Good evening.
Thank you,
Thanks,
Doctor.
everyone.
Thank you very much.